very fortunate as the Woodard family generously donated for this. Just to give you a little background, Mrs. Woodard had an aneurysm and was coiled here, and she did very well, and the family was very grateful, so they said they would like to endow an educational effort, and we decided to do this international symposium. This is, I think, the 5th iteration that we've had. We've always had somebody from each 3 continents. We sort of have this tri-continental approach. So I'm very delighted to see a full audience here and everybody here. So our first speaker today is, oops, sorry, that's the wrong one. This is the one. Our first speaker is Mike Fehlings, who's like one of the glitterati of neurosurgery. He's, I will tell you that I was looking through his CV, and he's published 778 papers with an H index of 78. The only person that I've ever met who's published more than that was Tom Starzl, who was the liver transplant legend, who had 1,100 publications. So he's a graduate of University of Toronto, did his MD, PhD from there. He's done seminal work on basic science of spinal cord. He's a very accomplished surgeon, really technically blessed surgeon. I'll tell you that I have an uncle in Toronto who had back problems, and the first person I think it was Mike, and my family members said, well, it takes a year to get in, but fortunately he was kind enough to allow them in. But he's really got all the awards in neurosurgery. He's given the Oliver Crane Oration, the Gross Award for Society of Neurological Surgeons. Published widely, been president of the CSRS Society. But most importantly, he follows Trudeau in fashion. His young Canadian Prime Minister wears really jazzy socks. So, in an attempt not to disappoint us, Professor Fehlings has worn his wonderful socks. So, without much further ado, Professor Fehlings. Thank you.
Well, cool. Here are my socks, by the way. Okay. It's an honor to be here, Professor, and thank you so much for the honor of participating in the Woodard Symposium. And it's a particular honor to be here with my 2 colleagues and new friends, Kate and Yigal. And so this is really super. So I'm just going to, over the next few minutes, try to share with you some of the excitement and passion that I feel for an area that's emerging and which will, I think, likely be a new specialty in neuroscience and in neurosurgery. And this is regenerative neuroscience. And we're embarking on this era. And so I'm going to talk to you a little bit about where we've come from and where we're going from a translational perspective. So I don't have any commercial disclosures, but a number of sources of grant funding. So this is where I work in Toronto, at Toronto Western Hospital, which is one of the major teaching centers at the University of Toronto. And please, you're all welcome to join us. And I know that you recently kindly hosted one of our students from Toronto, and we would very much like to reciprocate this. So I'm just going to show you kind of the face of spinal cord injury. But the face of spinal cord injury is also changing. And I remember every single person with a spinal cord injury I've ever taken care of, because each one of these injuries has a huge impact on the patient. So this is a best friend of one of our neuroradiologists, if you can believe it. I got called in a summer diving-related injury. 39-year-old man dives into one of the beautiful lakes in northern Ontario and breaks his neck at C4-5. It's a complete Asia A C4 injury. And I'm going to talk to you a little bit about what perhaps we might be able to do for a person like this, but there's nothing I can do that's going to be able to reverse this kind of an injury. But at the same time, small effects can have an important impact on quality of life. And so it's important to be realistic, but also not to be nihilistic. But the face of spinal cord injury is changing. So we're seeing an aging demographic. And this is actually the commonest type of spinal cord injury that's now seen in Western society. So this is a person with a severe central cord injury variant. And this young woman, she's 45. Here's how she injured herself. She went to take the garbage out in the driveway and she tripped and fell. And she became tetraplegic. And she's got ossification of the posterior longitudinal ligament. And she's got acquired developmental cervical stenosis. And she's got a cord contusion. But here's another type of spinal cord injury. And we're starting to push the envelope. And certainly in my area in complex spinal surgery, we're doing things we never used to do. But we're also finding that there are barriers, and it can be humbling. And so this is a prospective international study that I did with Larry Lenke, one of the prominent deformity surgeons. And we found that in extremely complex spinal deformity, like rigid thoracic curves in adults, revision surgery, the neurologic injury rate perioperatively is about 20 to 25%. It's very humbling. And so perioperative issues that arise is another type of spinal cord injury. And so this is an important area. And so advances here can have a significant impact. And the costs of care are staggering. And so spinal cord injury, next to neonatal distress, is the single most expensive human disorder to take care of. In each case runs into millions of dollars, even an incomplete injury. So we want to prevent these, but if they occur, we want to manage them expertly. So where are we going? So I'm going to talk to you a little bit about neuroprotective approaches, and I'm going to present the concept that early decompression stabilization for the injured spinal cord is one of the most important things that we can do, the concept that time is spine. And I've shamelessly borrowed this from the stroke field, where time is brain, and from the cardiac field. And the same thing applies in the spine. I'm also going to present a reevaluation of the role of steroids, because we've seen the pendulum go from one side to the other side, and I think it's time for sober, mature reflection and a realistic assessment in terms of what the role would be, and then to try to build on this. And then I'll talk to you very briefly about a trial that we're currently running with a repurposing of an existing drug. This is riluzole, which is a sodium glutamate antagonist. And I'll just touch on some other aspects of translational research, brain-computer interfaces, ways to modulate brain plasticity, and then briefly on biomaterials, biologics, and stem cells. So one of the advances that occurred in traumatic spinal cord injury is the recognition that traumatic spinal cord injury involves a primary mechanical injury due to fracture dislocation, ongoing compression, but there's ischemia that occurs. And this is some work that I did as a PhD student with Charles Tatter. At that time, we were working on what was called the vascular hypothesis of secondary injury. And everybody told us we were crazy and it was wrong, that everybody knows that there's no such thing as a secondary injury. Well, that's not quite the case. And in fact, it's now recognized that the primary injury is amplified by ischemia. So if you look at a cross-section of an animal that has a traumatic spinal cord injury, there's a disruption of the central vasculature. This is due to a primary mechanical damage. But around that area is a loosened zone, and that is the ischemic penumbra zone. And in this area, nerve fibers undergo progressive degeneration, and then this culminates in the neuropathology of a human spinal cord injury, where you have cystic myelomalacia surrounded by a glial scar, and you have anterograde and retrograde degeneration of the nerve fibers. And so we recognize now that a number of these mechanisms have clinical impact. Ischemia is the core event. This triggers a number of secondary injury processes. And I'll talk a little bit in the context of the riluzole trial about this concept that ischemia disrupts cell membranes and there are ionic shifts that occur. So sodium and calcium enter the cell, and there's a pathologic release of glutamate. And the number of these mechanisms converge in positive feedback cycles and result in programmed cell death or apoptosis. Okay, so this concept of time is spine. And, you know, it should be intuitive that if you've got pressure on the spinal cord and if the spinal column is broken, you should fix it. And it probably makes sense to fix it early. We would never sit on somebody with an epidural hematoma and progressive neurologic deficits, but the standard of care when I was a resident in training was to watch people with a spinal cord injury. We almost never operated, and if we did, we always did in a delayed fashion. And it was also felt that decompression of the spinal cord wasn't that important. And that never made any sense to me. And so when I started in practice in Toronto, I started operating people with spinal cord injury. I got a lot of pushback, and eventually we decided that we needed to do a prospective multi-center trial, and that's the Staska trial. And the Staska trial was one where we looked at early intervention for acute cervical spinal cord injury. And what we found, if patients were operated on at a mean time of 14 hours, within 24 hours, that the odds ratio of enhancing neurologic outcomes and major changes was almost threefold higher than the control group. And so from this, there have now evolved guidelines that have just been published, and this has been a collaborative effort, mainly led through AO Spine and with AANS, CNS, and other organizations involved. And essentially, what we've come up with are some recommendations for the first time that early surgical intervention should be undertaken unless there are mitigating circumstances. Now, the same guidelines development group also decided to take a crack at trying to revisit this whole methylprednisolone story. Methylprednisolone is like the punching bag of neurosurgery, right? Poor methylprednisolone, right? The irony is we use steroids like candy in neurosurgery, and somehow there's been this huge resistance to the concept of using it in neurotrauma. And there's all sorts of reasons behind that. But let's just put that aside. Let's just try to look objectively at the evidence. So one of the fallacies is, well, there's no basic science evidence to suggest methylprednisolone. I can tell you that when we design a lab experiment, you always have to have a positive control. We always use this drug as a positive control. I can assure you it has positive effects. It's anti-inflammatory. It protects against ischemic cell injury. It reduces axonal degeneration. Okay, so 2002, the guidelines came out from AANS, CNS in the spine section. And this was a bit controversial because there were randomized trials suggesting that methylprednisolone could have a small beneficial effect in traumatic spinal cord injury. But the recommendations here was that, yes, it's recommended, but at the option level. And I think that was actually the correct recommendation. The reason it was a correct recommendation was the effect sizes were small. There are some side effects that as clinicians we're obviously aware of with corticosteroids, and it was a secondary analysis. I think this is a correct recommendation. The problem is this recommendation, and this has medical legal significance. When you start saying that something is a level 1 standard of care, you get yourself into trouble. All right? So I had concerns with this. What if you have a perioperative spinal cord injury? What do you do? Do you get sued for that? Do you get sued for giving steroids or not giving steroids? So I thought, okay, you know what? Enough is enough. We need to look at this. And so what warranted this change in the recommendation that now is a level 1 recommendation? Well, there's only two things that allow you to make a level 1 recommendation. It's very clear. You either need to have a high-quality randomized controlled trial, or better, you need meta-analyses of randomized controlled trials. And there's no randomized controlled trial evidence to say that there's level 1 evidence that you can't use corticosteroids. So that's a problem. Okay, so what's new? Well, there are two pretty big pieces of information that were new that weren't included. One was that there was a meta-analysis of literature, which was a Cochrane review that was not included. That was a pretty big omission. And the second was that actually we had data from our Staska study, where we actually found that there was a synergistic effect of early decompression and corticosteroids in cervical spinal cord injury. And one of our thoughts is that neuroprotective drugs work better if you decompress the spinal cord, and there's probably a heterogeneous effect. So patients with cervical injuries where small effect sizes potentially can be translated into important clinical benefits like hand function might make more sense than, say, a patient with a thoracic Asia A injury where you'd have to have huge effects to see a neuroprotective benefit. Okay, so this was the Cochrane, review. The problem, though, and with the Cochrane review, is that it was authored by Michael Bracken. And Michael Bracken's a really smart guy, but he's also the principal author on the Staska study. So that was a conflict of interest. That was an error, I think, from the Cochrane collaboration. So because of this, we decided to redo all of this. So we had an independent biostatistical group, Spectrum Research, redo the meta-analyses. And these are the forest plots. And we also included a prospective Canadian cohort study that did not show a significant effect of steroids. And at the end, what we found was a small beneficial effect for corticosteroids. And so now, as a clinician, you have to think, okay, when could this make an impact on a patient? So in a cervical spinal cord injured patient, where small effects could be translated into improved hand and upper extremity function, that could be worth it. Maybe in an Asia A, thoracic A injury, a thoracic spinal cord injury, perhaps not. How do patients feel about this? So that's the other thing with guidelines development. You need to take into consideration patient perspective. So this was done through some authors in the Guidelines Development Group, and they actually asked patients to weigh the benefits of receiving corticosteroids versus the complications, and would they have wanted to receive corticosteroids? And the answer overwhelmingly was yes. And then, is it safe? Well, there actually is no evidence that it increases death rate. So in fact, there's a slight trend toward reduction in mortality. And there are no significant increases in infection, but the trends are slightly in favor of increased infection risk. And we know this. We use dexamethasone and other drugs all the time. We know there's slight increased risk of infection, and we manage this. Okay. And similarly, there are not significant differences in pneumonia, pulmonary embolus, but slight trends in favor of all of this. Okay. This is the Staska study, and essentially just the point to make here was that we actually had to control in the multivariate analysis for the use of corticosteroids because there was a synergistic effect that was seen. And we actually found in Jeff Wilson's PhD thesis work there was a reduction in complications with the use of corticosteroids in cervical injuries. And we gave the data independently to AANS and to AO Spine to do an independent review, and Joe Dettori did a very nice analysis on this, presented the data slightly differently, but found that there was a reduced risk of complications. Again, there's a heterogeneous effect in different patient populations with a spinal cord injury. So we put together this multidisciplinary guidelines development group, and it's really important that when you do this, so here's what you don't do. You don't go on a weekend with a bunch of your friends who think the same way, and they all agree with you, and you're going to do this. This was a 2-year process to do this. And you need to include people that don't necessarily agree with you on, say, the role and timing of surgery or methylprednisolone, but are willing to look at the evidence. So in fact, most of the clinicians that we had involved weren't using corticosteroids at the time, but it's about a 60-40 split. And we had a whole variety of different surgeons, various non-operative physicians, and we had non-medical healthcare professionals. We had patients, we had patient advocates, we had methodologists, and so on. And then this is the grade process. So there are actually YouTube videos on this. It's a really cool process. And so you take the evidence, and you need to do high-quality systematic reviews. You need to look at the clinical acceptability. You need to take into consideration patient values. It's a very important a concept. You need to look at the benefits versus the harms, and then you need to look at the costs. So it needs to also be reasonable to implement. So okay, so here's what we've done here. And we've tried to make sense out of 2 conflicting sets of guidelines. So what we have done is we've distinguished between the 24-hour infusion of corticosteroids, which was NASCAS 2, and the 48-hour infusion of corticosteroids. And that was not distinguished in the previous guidelines. And we actually suggest not offering the 48-hour infusion because this has slightly increased risk of complications. We also suggest not using the infusion of steroids after 8 hours. So here are 2 negative recommendations. But within 8 hours, we suggest that it is a reasonable option. So in other words, when things are gray, it's best left in the hands of the clinician. So we're just trying to present this as an option. If you choose not to use it, okay, but it's an option to consider. And in particular, I would consider using it in patients with a cervical injury, and particularly an incomplete injury, and we are routinely in Toronto. Okay, so surgery, corticosteroids. So these are things that we're using all the time. So what's emerging? So there are 4 therapies right now that are either in randomized trials or in proposed randomized trials. And they're all sort of repurposing of existing therapies, and they're all generic. It's very interesting where we're thinking about, and we can have a whole discussion on what's happened to the biopharma industry in this area. So cooling is being championed by the Miami project, and they just got a small grant from DOD. That hasn't started yet. GCSF is a pro-inflammatory cytokine. It mobilizes mesenchymal stem cells, and it's a rescue therapy that's used by oncologists for systemic neutropenia after chemotherapy. That's being looked at in Japan. Minocycline's an anti-inflammatory drug, and there's a small RCT that's going on in Canada, in Calgary. And then our trial is the riluzole trial. And riluzole is a drug that's approved for use in ALS, and it slows down the rate of nerve cell degeneration, and it's a sodium glutamate antagonist. And so what we're looking at is essentially repurposing of this drug. So I'll just kind of put this video together to give you a sense of what we're looking at. So we're studying patients with subaxial cervical injury. So here I'm modeling a C4 burst fracture. And so the primary mechanical injury is expanded by the secondary damage from ischemic events. At the level of the cell, sodium enters the neurons and the axons, triggers reverse operation of the sodium-calcium exchanger. Calcium gets in, proteases are activated, and there's a pathologic release of glutamate. So these are the classic mechanisms of excitotoxic cell injury. And riluzole specifically targets these. And riluzole is designed as a sodium channel blocker, and it indirectly blocks glutamatergic excitotoxicity. So in the clinical trial, we're randomizing patients with a cervical spinal cord injury. They're all receiving early surgical intervention, and then they're either receiving placebo or riluzole in the context of the trial. And this is based on quite good preclinical evidence, the idea that it's already approved in man in a neurodegenerative disease, and we also did a phase 1/2A clinical trial in 72 patients. 36 received riluzole, 36 control subjects, and we found improved rates of conversion on the ASIA scale and improved rates of motor recovery in the upper extremities. And the drug was quite safe. So we felt that we had quite a solid basis to proceed with. So the study has now enrolled 98 patients, and this is the largest randomized controlled trial in spinal cord injury since NASCUS and SIGEN, since 2 decades. So we've got another couple of years to go. Fingers crossed, we'll see how it goes. Okay. In parallel with this, we've also just recently completed a randomized controlled trial in degenerative cervical myelopathy. And these are patients who are getting riluzole perioperatively. They start 2 weeks prior to decompressive surgery for CSM, and then 4 weeks after surgery. And the idea being to amplify the beneficial effects with surgery with a neuroprotective drug and to mitigate against some of the perioperative complications such as delayed C5 palsy. So we'll be analyzing the results later this year and presenting the outcome of that trial early next year. Now, some other things that are going on. So this is cool. So this is a brain-computer interface. So this is the intersection of functional neurosurgery with restorative neuroscience. This is Ali Rezai, who did a fellowship with us in Toronto, and his group published in Nature this elegant paper where they took a patient who had a C2 a level of tetraplegia. That's an fMRI. They were asking this person to try to move the wrist so they could see, they could amplify the EEG signal from the motor cortex, drove this through a brain-computer interface, and were able to evoke upper extremity movement. So pretty out there, but potential solution for people who are locked in or for high levels of injury. Now, what else is going on now in clinical trials? So we're seeing a lot of activity after really a dormant phase. So bioengineered scaffold. So this is the work of Bob Langer at MIT. This is his company, In Vivo Therapeutics, and these are absorbable scaffolds that are microsurgically introduced into the cavitation lesion after an acute injury. Very compelling rodent and primate data to support this. So this is an early phase clinical trials going on. No results to report yet. It appears to be safe. Some early proof of concept work has been presented. Now, in terms of cell transplantation, this is largely right now in the preclinical arena with some efforts at early phase clinical trials. And the concept with cell therapies is that they work in 4 principal ways. They either replace lost cells, they provide trophic support for the surrounding environment, so releasing growth factors. They may immunomodulate the environment to mitigate in some of the local inflammatory effects, and they may in some cases provide scaffold support as well. And although there's a heterogeneous number of cell therapies, where the field is evolving to is focusing largely on the use of neural stem cells, the developmental building block of the central nervous system. So this video will just illustrate some of the concepts that have now been translated into early phase clinical trials. And this is the idea of using neural stem cells to remyelinate residual axons. So I don't need to tell this audience the idea of myelinated white matter fiber tracts mediating axonal potentials. So we have the nodes of Ranvier with clusters of sodium channels, the myelin, which is made by the oligodendrocytes, adhesion molecules such as Casper that link the myelin to the axon. So after an acute spinal cord injury, as I showed you in some earlier slides, there is a central necrosis that occurs of the spinal cord. And typically, there's a subpial rim of axons. And the oligodendrocytes undergo apoptotic cell death, and there is limited remyelination that occurs. And so there's a demyelination and axonal conduction block that occurs. And there's also molecular derangement of the axons. So what's being moved forward in a number of early phase clinical trials is the idea of using the patient's own spinal cord as an intrinsic scaffold to facilitate neural repair and regeneration. What's cool with these neural stem cells is they really like the white matter niche, and they pathfind their way along the white matter, and they find these demyelinated axons and remyelinate them. And so this has been a bit of a struggle. We've seen some biotech startups like Geron that have struggled. Stem Cell Inc. has recently struggled. Asterias has now taken over. And the reality is that the technology right now is promising but imperfect. And so there's a considerable amount of preclinical basic science that's required to try to amplify the effects of neural stem cells. But it's an initial start. And then the final story I'm going to talk to you about is the whole story of trying to overcome the inhibitory environment in the central nervous system, so that blocks regeneration. And this is kind of a simplified cartoon showing some of the key inhibitory molecules. So on the bottom, I've just diagrammed a neuronal cell membrane, and it expresses a receptor called the NGR receptor. This is activated by a number of molecules that are on the inner leaflets of the myelin, including NOGO66, oligodendrocyte myelin glycoprotein, and others. And when NGR is stimulated, it activates a GTPase downstream called Rho. And when Rho is activated, the growth cone collapses because the actin cytoskeleton gets depolymerized. And that's why in the CNS, you have a process that Ramon y Cajal called abortive regeneration. The neuron sends out the growth cone. In the peripheral nervous system, you get the regeneration occurring. In the central nervous system, Rho is activated, the growth cone collapses, and you get a failure of central nervous system regeneration. So Lisa McCarricker, who at the time was a colleague of mine in Montreal, made this discovery about Rho activation. This worked with a number of other scientists. And I had the good fortune to collaborate with her to develop this molecule called Sethrin. And it's now been taken over by Vertex Pharmaceuticals, and they call it VX210. So this is a recombinant protein Rho GTPase inhibitor. And the way this is introduced to spinal cord is cool. So you do a decompressive surgery, say if somebody has an acute spinal cord injury, and then at the conclusion of the procedure, you topically apply this extradurally in a fibrin sealant. And the molecule has been engineered to penetrate soft tissues very well. And so it actually enters the spinal cord fairly well. And we did an early phase clinical trial where we showed, particularly in the cervical population at 3 milligrams, quite promising rates of neurologic recovery. The results in the thoracic Asia A subjects a little less promising. So based on this, there's now been a large phase 3 randomized trial which has been launched, one of the few pharmaceutical companies in this sector. So this is currently in the works. So what I've tried to share with you is kind of my life's work and where things are going. There's a lot of excitement in the field. So I want to leave with you the concept of time is spine, and that we have an important role for early decompression in spinal cord injury. I've tried to present kind of a recalibration of the role of steroids. That it's a gray area, but it is an option. Talk to you about some of the promising protective therapies, a little bit about some out there bioengineering methods of brain-computer interfaces, and then kind of summarize some of the key areas in regenerative neuroscience, neural stem cells, biomaterials, and biologics. So just in closing, I want to thank all of you for your kind invitation, and I particularly want to thank my team. I still work with my mentor, Dr. Tatter, and I hope to see many of you in Toronto next summer for the International Neurotrauma Symposium. Many thanks.
We have time for a question or two. Hi.
I find the inhibitory nature of the CNS regenerative process interesting. Why do you think that is? Do you think there's any kind of evolutional base for this kind of inhibitory process for repair?
Yeah. So it's a really good question. So the question was, why would nature design inhibitory processes to prevent central nervous system repair and regeneration? And so developmentally, there are start cues and stop cues in the central nervous system that mediate the development of the central nervous system. And so if all you have are start cues, what will occur is that you won't get an organized central nervous system. So for example, when the visual cortex develops, we're born with 3 times the number of neurons that we require. And so there's a process of pruning that occurs. It's called apoptosis. And then a lot of these signals that prevent regeneration are stop signals that are there developmentally as the central nervous system myelinates to stop the growth of the neurons to mature the central nervous system. And then there's some school of thought that processes such as the glial scar have been evolved so that if an area of the central nervous system becomes dysfunctional due to trauma, disease, stroke, you pay the price, you wall it off from the glial scar. If the area is small enough, you can cope without that. But of course, as occurs in disease processes, many of those same processes that are there developmentally in disease processes are involved in preventing recovery. But that kind of from a developmental perspective is kind of the purpose of some of these stop cues.
I have a practical question for you. In your first case, did you show the lady with the ossified OPL?
Yes.
So we see this a lot in clinical practice, Somebody has a small disc and a surgeon will tell them, oh my God, you go or bump in the parking lot and you're going to be quadriplegic. And so this sort of fear factor. What are your guidelines if a C5-6 disc came to you, if there was no cord edema but significant compression, if there was cord edema, when do you intervene, say, in an asymptomatic patient? And what do you tell them? Don't go bungee jumping? Or I'm just curious about that.
Okay, so this relates to people with degenerative cervical myelopathy and who, let's say, are imaged because they have neck pain, or maybe they had an episode of radiculopathy which is resolved. You examine them and they're neurologically intact, but they've got spondylosis, and with cord compression. So we actually, part of the focus issue that we just put together covers that topic. And the current recommendations are to advise the patient that they have a condition that could lead to cervical myelopathy, that they need to be aware of this and they need to be monitored for the development of cervical myelopathy. But the advice is against doing prophylactic surgery. The evidence doesn't support it right now. Even if there's cord signal change, which I sometimes do feel a bit uncomfortable about, but that's where the evidence is. That's where the evidence is right now. Where the future is going to be going, though, is we recognize that many of those patients will remain stable, but some won't. So about a quarter will decline in about a 3-year period. And so right now, some of the research that's going on is looking at biomarkers, such as microRNAs, to actually discern which patients are more vulnerable for deterioration, or to use advanced microstructural MR imaging techniques to say, okay, you know what, there actually is objective damage in the spinal cord. You should consider the option of having early surgery.
Thank you so much, Michael. Appreciate it. Our next speaker is Yigal Shoshan, who is the head of neurosurgery at Hadassah University, which is one of the best centers in Israel. He went to medical school in Haifa and then did fellowship at the Cleveland Clinic and has covered neuro-oncology. He's really considered one of Israel's best neurosurgeons. He does a lot of skull-based tumors, trauma. And my personal connection to him is one of my best friends in residency was Shlomo Pomeranz, who used to be an attending at Hadassah, who's actually been here as visiting professor. Unfortunately, he passed, but we've always had a great connection. And so we're very fortunate. He's very well published. He's an expert. And I always tell people he's one of Israel's best neurosurgeons. So without much further ado, Professor Yigal Shoshan. I put a little pictorial on Jerusalem and stuff there, too. You want to switch?
Thank you, and good morning, everybody. Thanks, Anil, for your kind invitation to be here today with you. My topic is somewhat problematic because it's not, it has some non-medical issues as well. But I will not go into them. I will just share with you our experience in penetrating brain injury related to terrorist bomb blast, which I think it's quite unique. And you know, the incidence of penetrating brain injuries is becoming more and more. We're all aware of the tragedy that happened this week in Las Vegas. It happened everywhere. It may happen every time. And we as a neurosurgeon should know, and we should be prepared. So yes, I come from Israel. The physical location is Israel is in the east part of the Mediterranean Sea, as you can see here. Here is Egypt, Jordan, and Syria, Lebanon. Here's Jerusalem, physical location here in the center of the heart of Israel. Jerusalem is a very important city for many religious. You know, the Haram Sharif, the Dome of the Rock, and Al-Aqsa Mosque are there. Of course, the Burial Church, very important for the Christian world. The Western wall is important for the Jewish people. And there are many other symbols in Jerusalem, like David Tower. So it is a very political and it's a very emotional, loaded city, Jerusalem. And it has about 1.2 million inhabitants, which is about 11% of the overall Israeli population. Look into Jerusalem. The Hadassah University Hospital system, from which I came, has two campuses, one in the west over here and one in the east over there. It's about 1,100 beds altogether. And the neurosurgery department, which is the only neurosurgery department in Jerusalem area, is located here on top. Have 10 neurosurgeons, 12 residents, and 2 fellows at any given time, 35 adult bed and 12 bed of neuro ICU, as well as pediatric neurosurgical service with 8 bed of pediatric ICU unit. But first, I would like to go over some general aspect of penetrating brain injury, and we start with history, like with everything, and I love history. So the history of penetrating brain injury basically dates back to the Harvey Cushing experience in France in World War I. And our present knowledge about the surgical management of penetrating brain injury lies in the battlefield. And the foundation that Cushing laid out in the pre-antibiotic era included debridement, removal of hematomas, dual closure of the skin, and only implementation of these principles decreased mortality significantly. In the Second World War, the antibiotic was first introduced, penicillin and sulfa, and that reduced mortality even more. And in the Korean War, the air evacuation was the first time presented, which shortened the time for soldier, for treatment, which reduced also significantly the mortality. And in the Vietnam conflict, That was the first time that was prospective data collection, the imaging modality that were available with X-ray and angiography. And at that time, because they have the X-ray and they saw in the X-ray the bullets or the bone chips, the removal of bone chips was mandated by the US military, and sometimes second and third operation were done to remove those bony or bullets from the cranium. But that was changed in the Lebanon conflict in 1982. That was coincides with the introduction of the CT. It was widespread clinical use. An Israeli database from that war showed that some shift of paradigm, that it is unnecessary to go after deep location or deeply located foreign bodies, just deal with those that are accessible one. In the Iran-Iraq war, so Arabi was first introduced the vascular injuries that are related to penetrating brain injury. We'll talk about that later even more. And he mainly described the pseudoaneurysms. And then the decompression was introduced in 2003, and that became one of the more fundamentals, not only in penetrating brain injury, but also in traumatic closed head injury as well. Vasospasm was following a blast injury was reported by Armoda by 2006, and that the peak time for this cerebral vasospasm was after 2 weeks. So, ballistics. Well, as you may know, the velocity is very, very important here. The kinetic energy is related to the mass and the square velocity. And that's stressed that the velocity is a very important issue, and that's why was a traditional classification of low velocity injury and high velocity injury. Just for instance, in modern rifle, the exit speed from a rifle is above 700 meters per second. It's an M16, Kalashnikov, and many others. Handguns basically between 200 to 400 meters per second. Shrapnel will have about 100 to 200 meters per shrapnel, and rubber bullets, which also become more and more popular now in police use, in riot and demonstration all over Europe, also here in the States. It's very low, it's about 60 meters per second. So what we need to know about it, that basically missile energy is very greatest at launch, but it's decay with length and time. And in fact, what is important is the impact velocity between the head, in this instance, and the missile and the missile itself. But velocity is not the whole story, because also tumbling, yaw, and fragmentation of the bullet itself, or secondary missile in the form of bone chips, are also important, and they enhance the damage or the damage delivered to the tissue. This is an instance we can see here. A ball bearing was launched into the skull, reflecting some bone chips to the brain, causing intracerebral hematoma. There's another example of tangential injury. It was not really penetrating brain injury, just a tangential injury with a bullet going this direction, but that was enough to cause some injection of bone chips into the brain, in this case causing interventricular hematoma. So what we really need to know about ballistics, okay, low velocity handgun from a very short distance can cause devastating injury. On the other hand, a high velocity rifle from a great distance, the soldier that had protected with a helmet and everything, can result in quite survivable injury. So there is no dogmas in this regard, and that excludes snipers, because that's different ammunition, different setup, and we're talking about urban penetrating brain injury and not military setup. You can see here in this film very beautifully the transfer of the kinetic energy to a pressure wave that purpled radially in this block of gelatin. And initially we have a direct a cylindrical permanent cavity, and also a temporal cavity that expand and contract within 20 milliseconds. And this expansion and contraction may leave behind a large amount of blood due to a stretch injury of small vessel around the permanent cavity. Usually, people are saying that the exit wound is larger than the entry wound. That's right, but not for short distance. In our experience, from short distance shots, they are similar. But we need to keep that in mind. Other changes that happens is a sudden rise in the ICP and as well as the arterial pressure, the mean arterial pressure. But the rise in the ICP is very, very larger in magnitude and more sustained over time. And within 1 minute, the CPP drops from 90 to 50, and then the cerebral blood flow drops also by 50%. You can appreciate here also the sudden rise of the ICP while the bullet or the missile is passing through. But this is not the whole story, because this pressure wave also causes respiratory arrest or apnea. You know that the delicate medullary respiratory centers are just located in the floor of the fourth ventricle that has a fluid, and the pressure waves go through the fluid over there, and that can cause some shock wave to the respiratory centers which may cause apnea, and that's also contribute to ischemia and hypoxia. In bomb blast, there is additional issue here because it's a combined effect of the bomb blast itself and penetrating brain injury. The high energy blast front with low velocity, multiple projectiles. You can see here, for example, that's an explosive. Nowadays, people can prepare explosive by the internet almost everywhere. And this is the shrapnel that are embedded in this explosive. And when this complex is activated, especially in a closed area like a bus or cafeteria, it's a devastating damage. You can see here, this is bus number 19, not from our hospital. 19 people were killed here on spot from that. A bus is a very common transportation in Israel, and that's why this was a target for suicide bomber in Jerusalem. This is like bus number 32, like it looked like before, and this is after explosion. So there are multiple objects that the terrorists use in their bombs. As you can see, metal balls, hexagonal nuts, ball bearing, nails, rod segment, whatever. Everything can be there. This is a nail. It didn't have enough energy to penetrate the skull, but it lodged over here, and then you can see it here very nicely. We showed that before. That's a ball bearing. This is a hexagonal nut. It's heavy and irregular, and its potential damage is even higher. You can see it here, all over the body in this case, and also transversing the cranium in this case, as you can see here. And that's that was outdoor suicide bomber in the Zion Square in the center of Jerusalem. So what about the assessment? So initial assessment is, the trauma guys are sitting probably here, and I'm not going to make a lot of new things here, but just go over the setup that we used to do it in Hadassah when we have this terror event. ABC, prevention of hypoxia, prevention of hypertension, and then brief neurological evaluation, Glasgow coma, pupils, focal deficit, and that's concomitant evaluation by the trauma team. This is one of our patients that came from a bus bombing by a suicide bomber. You can see he treated by cardiothoracic, general surgeon, and neurosurgeon as well. Examination of the cranium and face is very important for entry and exit wound, for the breast fracture, and you can surprise how easy it's to miss an entry point or an exit point of a bullet, especially when the face are very swelled. The eyes is a very common site of penetration, and if you don't look after it, you won't find it. For example, here you can see it, and on CT, you can see the shrapnel destructing the orbit. You need to look for CSF leak, for carotid injury, usually with profuse bleeding that might be often fatal. In our service, every sign of herniation, our practice is to give a mannitol high-dose moderate hyperventilation even before going to CT. That's on the way to CT, so before the CT. Anticonvulsion should be given to all patients. If you have seizures, of course, stop it with the diazepam and lorazepam, but all patients will have a loading dose of phenytoin. CT is the imaging of choice, at least at this area, because it shows the extent of bony injury, missile tract, and extent of brain injury, hematomas, intracranial air, foreign bodies, and cerebral edema. There are some bad prognostic factors or signs on CT, which is bihemispheric injury, transventricular trajectory, interventricular hemorrhage, and diffuse edema with effacement of the cisterns. Here's an example of a master's student in the Hebrew University in Mount Scorpius was injured in the cafeteria by suicide bomber. He came to us with this CT, transventricular, interventricular blood. We inserted the EVD, was drained for 3 days, then it was stopped. The ICP rise above 70, and he died. There is another case of transventricular injury. We treated this patient with EVD, and he ended up with Glasgow outcome 3. So transventricular trajectory, bad sign. Surgical management, the goals, not different from those that Cushing made in 1917, basically. Debridement, removal of hematoma that causing mass effect, removal of accessible bone fragments, and decompressive craniectomy if necessary. Bone chips, removal of accessible fragment. Unnecessary to remove inaccessible bone chips fragment. There is no a lot of database on that, and there is no double-blind studies on that. It's just an experience that was gained during the years. This is one of our patients here. You can see here right frontal penetration with a shrapnel. There are some bone chips here and also in the depths. We did a debridement. We removed those one. We left those behind. Initially, she was hemiplegic, but later on, she had 6 months after rehab, she had no drift. Dual sinus injuries, life-threatening injury, massive hemorrhage possible. You must be prepared with blood product in the OR, and sometimes we even don't have time to take the patient to CT. We run from the trauma room to the OR and try to block or tamponade this bleeding. The indication for ICP monitor is like in severe closed traumatic brain injury, Glasgow less than 8, interventricular hemorrhage, significant intracranial hematoma, and brain edema. Ventriculostomy is our method of choice because it allows therapeutic drainage. Sometimes it's very tricky to put a drain in the ventricular system, especially in this patient. Don't hesitate to use neuronavigation for that. It will assure you an accurate placing of the tip of the catheter. We recommend antibiotic impregnated catheter, and you usually leave it up to 10 days, but also intraparenchymal monitor is also reasonable to use. Anticonvulsant therapy we give all patients because the frequency of convulsion and penetrating compared to close is much higher, and the first week is about 10%. So prophylaxis is clearly needed, at least for the first week. What about antibiotics? It is a contaminated bombs, and it's a contaminated business. So we cover all patients with antibiotic. Foreign object, maybe their skin, hair, bone fragments. In the modern area, the rate is up to 11%. Mostly staph and strep, but we see more and more gram-negative that coming from the community and anaerobes. We prefer to risk factor that may contribute to infection, CSF leak, air sinus wound, and wound adhesions. We prefer, of course, broad coverage for staph and strep and community-acquired gram-negative and anaerobe. The duration is unsettled. Prophylactically, we give about 7 days antibiotics. What about complication? There are 4 major complications: CSF leak, migration, pseudoaneurysm, and infection. CSF leak can be acute or delayed, especially in those that are penetrates through the skull base. CSF drainage via lumbar or interventricular drain is the first option, at least in our hands. And if the leak is persistent, then you perform a CT with metrizamide, or if you don't have a metal object, MRI with high-resolution T2 protocol with gadolinium to try to identify the port, the area of the leak, not always possible, and then to plug it via craniotomy. Migration is rare, may result in neurological migration of the bullet, and may result in neurological deterioration. Crossing of midline is possible, and that might be one of the indication to remove the bullet. The most common type of vascular complication after penetrating brain injury is aneurysms, or pseudoaneurysm, which is a complete disruption of the arterial wall in which you have the defect is bound by hematoma, fibrin, and brain. It's rarely a true aneurysm. The incidence is up to 8%. In our series, it's much higher than that. I will show it to you later. And the location is typically along first and second degree branches of the major arteries of the brain. Crossing midline is a risk factor for pseudoaneurysm, 2 dual compartment, diurnal entry, and we need to keep that in mind. Angiography is our diagnostic test of choice, and if the aneurysm is there, we treat it by endovascular or by a surgery. This is a case of a 17-year-old girl who injured in a bus explosion. You can see here air in the ventricle and a small hematoma here in the right basal ganglia. She presented with right severe hemiparesis. And she had a ball bearing here in the right frontal lobe. 3 days later, we repeat the CT. We don't see the ball bearing here. There's some subdural collection. We move down. We show that it's a migration clear across the permanent cavity that we discussed before, all the way down. You can see it very nicely here in the reconstruction. And because it crosses the midline, we did an angio. And you can see here right pericallosal artery pseudoaneurysm. Now remember, she had already right hemiparesis. So if you damage this artery, this girl can end up with paraplegia. So we had to be very careful about that, and we decided to go with a very, very small coil and to close it. Luckily, our endovascular neurosurgeon was able to do that. She did a nice recovery. She came later on, about 2 months later, to remove of that body with the shrapnel, the navigation system. You can see it over here. And she went home 2 days later. This is another patient with the injury penetrate here just below the infraorbital area of the right eyes. You can see here subarachnoid hemorrhage and devastating damage to the right orbit. She heard the ball bearing. We decided to treat her with ventricular drainage. She had also some multiple ball bearing lounge everywhere. Here is near the vertebral artery. Of course, we did angio. It was negative. We treated her with EVD, and here is she 1 year later. Overall, we have more than 2,000 terror victims treated in both Hadassah since September 2000. And this is almost half of the overall number of people injured in terror attack all over Israel during the same period. 111 of them had a brain injury, and we had 47 admission to neurointensive care. Those that had suffered from penetrating brain injury related to a terrorist suicide bomber, 25. As you can see, all ages here, male, females. Important to know that in busts and indoor, about 15, most of them, so outdoor. We know that indoor, the damage and the prognosis is much worse compared to outdoor explosion. This is the procedures that our patient went, and here are some demonstrative cases. This is a 3-year Arab baby who was sitting on his mom on the back part of the bus while the suicide bomber was activated. We did a debridement here and a removal of the hematoma. The baby looked quite well. He was intubated, of course, ventilated, but responding very well. Crossing midline, we did an angio. to right A2 pseudoaneurysm. You can see it over here, and this is with highly selective catheterization, and we plug it with histoacryl glue, and the baby did a wonderful recovery. This is another problematic case of a 23-year-old male with Glasgow 6, injured by a shrapnel. You can see the shrapnel goes here in the occipital area, all the way up to the contralateral side. See here some interventricular hemorrhage, traumatic subarachnoid hemorrhage, multiple contusion, and also multiple fragments, bony chips, or shrapnels. We decided to insert, we did a debridement here, and we put an ICP, Lycox, and also the Hemedex for cerebral blood flow. Took him to the unit. It was intractable elevated ICP, was taken to the OR. In the OR, both pupils became fixed and dilated, and we did an emergency bifrontal craniotomy. So after the compressive craniotomy, the ICP was well tolerated, and because the cross of the posterior cerebral artery territory, we did an angio, and as you can see here, there is an aneurysm here in third generation calcarine branch of the PCA artery. This is the road map angiography. You can see here highly selective catheterization. This is shrapnels. This is not the aneurysm. This is the aneurysm is here. And this is before aneurysm, shrapnels. This is post angio. 6 months later, the patient came for cranioplasty and removal of this foreign body. We did the cranioplasty here. You can see here the bare holes of the ICP and the Lycox. And this is the CT 1 year later on. You can see here the track of the shrapnel. Glasgow outcome score of 4. This is another case of an 11-year-old boy with a penetration here in the left frontal lobe. We did a debridement and removal of the bone. You can see here the shrapnel is a ball bearing. We did an angio. You can see here second branch of left MCA aneurysm. See it very clearly, and that's coiled with histoacryl glue. This boy did a very nice recovery, and he even invited us for his bar mitzvah 2 years later. This is a very interesting case, and this is my last case. This is the very interesting case that we received from another hospital. He was injured by bone blast, not was penetrating, but only bone blast. You can see here subarachnoid hemorrhage, air. There is a little crack here at the area of the anteroclinoid. His ICP was not controlled by conservative management, so we decided to do a right hemicraniectomy for him. And then 3 days later, he developed a complete oculomotor on the right side. That's a new neurological deficit. It was not before. We repeat the CT. We see here some blood. We did a CTA. And you can see here, again, pseudoaneurysm here. It looks like it's from the carotid artery based on the CTA. Of course, we did an angio, but that was a PICOM pseudoaneurysm, probably due to the injury by the bone chip from the anteroclinoid that caused here. We decided to coil this one and to put a stent to protect the carotid artery, and this is the angio 6 months later. So we had 3 cases of migration and 5 cases of pseudoaneurysm in this 25% group of patients, 20%. CNS infection 2 and wound infection 1. So overall, there were 22 survivors among our 25 patients. And the Glasgow outcome score, as you can see here, was not bad. Most of the patient was in 5-4 at the end of the follow-up time. So to summarize, a good rate of survival and good functional outcome are possible even in severely injured patients with penetrating injury from terrorist bomb blast. Among survival, rate of good outcome can be high with aggressive management. But the most important thing is that the possible complications such as vascular injury, missile migration, CSF leak, and infection must be anticipated and treated aggressively. Certain patients may benefit from removal of foreign body in the late phase of recovery, but that's a question that's always open for discussion. I would like to thank our patient for giving us the permission to present their cases here for you and the picture here for you today, and I thank you for your attention.
You know, any questions? I had one question about migration. We've never seen that with bullet fragments. Normally they'll stay in that part of the brain. And do you think it's the density, or why did this migrate down like that? I've never seen anything like that.
Well, it's reported. I mean, we don't see it in bullets, but in the shrapnels. Shrapnel is different. You saw the kind of those shrapnel. They are irregular, and they create probably some larger volume permanent cavity, and that's allow the shrapnel to migrate. With bullets, it lets happen. Real bullets, it lets
I
happen.
thought that case was fascinating. It went right across the brain.
Yes. I will have another 2 cases also.
Any other questions? Thank you so much again. Appreciate it. Our next person is Dr. Drummond, who's a native of Sydney. She grew up in Sydney, Australia, went to Sydney Medical School, did her training there. Then she was at Harvard, at Boston, did neuro-oncology fellowship for 4 years. She's now in Melbourne, and she runs the program there, has published a lot. She's also the editor, was the associate editor of the Journal of Clinical Neuroscience, and she's on the board of the Royal Australasian Society of Surgery, so she tests these candidates for their exams. She's a great educational person, great resource, and has been a real leader of neurosurgery in Australia. When I first met Kate, we realized we were both fans of Game of Thrones, and her medical students call her Mother of Dragons. So I always refer to her as Professor Khaleesi. So without much further ado, Professor Khaleesi.
Although not many people think that I need a microphone, I'm pretty loud. So I'd really like to thank Professor Nanda for having me here. It's a great honour to be able to speak at this symposium. Yigal I've known for many years, and Mike I've only met twice, but it's great to be part of a great team. So we're going to change gears a little bit here, although I think Mike's spoken a little bit about how finding out how the patients feel that they're actually doing in their treatment of whatever neurosurgical disease they have is very important, and that's something that we've embarked upon a very large project about quality of life in brain tumours. And do we understand it? Do we know what our patients think? And what are we actually doing to improve it? Or what can we do? So this is my hospital. This is our very nice, fancy new cancer centre, just built. We call it the Purple Palace. There's so much purple inside. Behind it is the Royal Melbourne Hospital, my main hospital, built in the 1940s. It's so bad that they've had to put wire on the outside walls to stop the bricks from popping out and injuring people. So we're hoping that the government might pay for a rebuild soon. Women's hospital, children's hospitals down the road, and University of Melbourne over here. So quite a large biomedical precinct. Our treatment of brain tumours is, I guess, what we would consider relatively on the aggressive side. We've just installed an intraoperative MRI. Most of our low-grade glioma surgeries are awake. Gamma knife hasn't really landed very much in Australia yet, so most of the acoustics are still done surgically. And so, we have a lot of patients who are treated surgically who I'm looking after in my outpatient clinic. And I was starting to think that I didn't really understand how they were actually doing. Of course, I can show you a picture of our very impressive hospital site, but what I find that most people in North America are actually interested in is this is our ballpark. The Melbourne cricket ground holds 100,000 people. That's a really big ballpark. I like to show that in Boston because Fenway's only like 32,000, something like that, Melbourne City in the background. So Health-related quality of life. So you'll know that the WHO definition of health is a complete absence of any version of unhappiness, illness, depression, anything else. So no one's really healthy, but health-related quality of life is self-assessed, multi-dimensional concept that encompasses physical, emotional, and social components of quality of life. So it's quite a broad concept. Self-assessed is really important because physicians tend to look at sort of physical things. Can they walk? Does their arm move? Can they talk? But patients often see that very differently. Even partners or proxies will assess quality of life differently to what the patient themselves is. So this idea of patient-reported outcomes, how the patient does is the most important outcome, and the idea of managing survivorship. We have many long surviving patients now, either with benign brain tumours or low-grade brain tumours, and we have to manage their survivorship in an appropriate way. So this is becoming an increasingly important concept. And I had an idea that I didn't really understand it. You see a patient post-operatively acoustic neuroma 3 years, and you think they should be great. And yet they're dizzy, I'm dizzy, I can't walk, I'm unhappy, I haven't gone back to work. You'd see a low-grade glioma patient at 2 or 3 years, and they're like, I'm great. Is my scan good? Fantastic. My scan's good. I'm great. I'm fantastic. So that patients who we thought were in a more parlous sort of situation are actually feeling that their quality of life is better than the surgically cured patient. And so I thought it was important to investigate this. Now, of course, it's not just my idea. All the clinical trials now are looking at quality of life as an outcome, along with, say, progression-free survival or overall survival. This is the big low-grade glioma trial randomized to early radiotherapy or early chemotherapy, and quality of life is an important outcome measure. Surgical strategies, aggressive versus non-aggressive, quality of life after surgery or radiosurgery, or watchful waiting for vestibular schwannoma. All of these are being looked at very carefully, but these are very specific populations. They're unidimensional. If you have this or this, how do you do? They're clinical trial populations, or they're only looking at one intervention. And of course, that's not most of the patients we see. Most of the patients that we see, their quality of life is related to a treatment factor, but also factors related to their tumour, patient factors, or their environment, all comes into their quality of life. So a lot of what we learn from clinical trial quality of life outcomes is not actually relevant to the average patient that you see sitting in your outpatients. And so I didn't find it necessarily that helpful. We'd done some previous work. This is Lizanne Jenkins, a neuropsychologist. We'd done quite a lot of work showing that there were subtle differences in our brain tumour patients who we thought were functioning very well. So she designed some incredibly elegant experiments where she showed movie clips and facial expressions to patients who'd had surgery in the frontal lobe, particularly the prefrontal cortex, and also normal controls, and found out that our patients often can't recognise fear, for instance, as opposed to disgust or as opposed to happiness. And also that they have a different emotional response to watching movie clips of things that should induce unhappiness or fear or whatever. And so she found out that there were subtle differences that might not be obvious, and she found out that carers rated this very differently to patients. And so we knew that there were subtle differences, and also an idea of theory of mind, that they had no empathy of what was going on in the other person's mind. So we knew there were subtle differences. That informed that perhaps we should look more closely at how our patients were doing out there in the big wide world, or how they felt that they were doing. So this was the research question. It was fairly simple. I picked low-grade glioma, meningioma, and acoustic neuroma as patients that they were under my control in the clinic. They came to kind of the surgical side of the multidisciplinary clinic for follow-up. They had long survival, so we could look at what happened to them over time. And basically the research question was, what is their longitudinal health-related quality of life in an unselected clinic population? So nothing to do with what treatment they were having or what treatment they weren't having, just our group of patients. almost all who had been operated in some way. And I also picked them because there were some points of difference, intraaxial versus extraaxial, surgically cured versus a disease trajectory that would eventually lead to death, but enough time to watch these patients. What's their longitudinal health-related quality of life? What are the determinants of this, and what interventions could we do to improve it? So we surveyed the unselected outpatient group with these at every clinic visit that they had for 5 years. Well, that's what we're in the middle of doing. This is a work in progress. We used these quality of life questionnaires, which I'll explain in a second, and we took some medical and social history. It was obviously ethics approved. The inclusion criteria were just those tumours, age greater than 18 years and a basic literacy in English. Patients consented, and it took about 15 minutes to complete. And basically I have an army of medical students who come and do research with me every year, and they just go to the clinic, find the patients, give them the questionnaire, put them in a quiet space to do it, and bring them back and collate the data. So it's a pretty simple project, but no one's actually done it in this way. Why did we pick those questionnaires? The main one was that there's this enormous over 16,000 person reference population for this, the EOITC Cancer 30 quality of life questionnaire. And so we've got a normal population, so we don't need to look at normal controls. What do these questionnaires involve? Well, they involve a number of scales: global health status, how are you going overall, number of questions on that. 5 functional scales: physical, role, emotional, cognitive and social functioning. Some 9 single symptoms or scales or items. And the score from that is put in a range of 0 to 100, linearised, with 100 being perfect quality of life and 0 being poor quality of life. And the symptom scale is the same thing, but the higher number is poorer quality of life because it's greater symptom burden. And then the BN20 is an additional 20 questions specific to brain tumours. So this is a general cancer one used across many studies, and this is brain tumour specific. So scored by the patient in the waiting room, scale of 1 to 4 or 1 to 7, depending on the question, not at all to very much, and transformed. We took some medical history as well, just things that we thought might be important. It was just a bit of a grab bag. So I'm going to tell you about the first 2 years and then what went on from there. So this was our first 2 years, and for the first 2 years we actually had another control group apart from the published normal population, which was a spinal control group, just a control for people treated in our unit with a non-brain tumour disease, simple spine, and it's been done before in other projects. The groups were relatively comparable, except so 483 patients in the 2 years and over 300 with brain tumours. The low-grade glioma cohort's a little younger. The time since surgery is a little shorter in the spinal cohort because they don't tend to be followed up so long. And obviously the meningiomas, there's a female predominance. And this is just the normal control population that I talked about. So that's our group, and the findings that sort of have informed what we've done from there were really interesting. So look at the orange. This is the normal population. So just remember, nobody has complete health-related quality of life. Even normal people sort of score themselves down at around 75 for their global health-related quality of life. And so no one's normal. So everything needs to be looked at in that sort of... and then look at the spinal population. Even for cognitive function, they relate themselves really poorly. And I think this is going to be an interesting another project that someone's going to want to take on, because it's about expectation. It's about expecting to be cured. It's about expecting to return to function. It's about what's called response shift. So the people with the brain tumours don't expect to do well. Oh my God, I've got a brain tumour, so clearly I'm not going to be as healthy. So it's very interesting. I mean, there's lots of problems with using a cancer questionnaire for spinal patients, but it is a very interesting baseline. So I think we need to put a little bit of time into the quality of life of our spinal patients, but that's kind of not my job. So we've closed that off now, and we're not continuing to collect from spinal patients. But because it depresses me too much. But in all domains for the brain tumour patients, the quality of life was significantly reduced, but probably not by as much as I thought it would be compared to the normal population. And it's really, really that emotional, cognitive and social domains that they find most problem with. But the other interesting thing was the three types of tumours were not that much different from each other. You know, you'd think that the low-grade gliomas would be doing a lot worse, and yet they weren't. So this was very interesting for sort of our first 2 years. And what did we find out that were the determinants? Well, poor global quality of life is basically associated with poor subjective cognitive function. The other things that were associated were unemployment, the inability to drive, anti-epileptic use and seizures. Not that unexpected. And poor subjective cognition was associated with seizures, fatigue, sleep difficulty, headache and pain. Well, those things were kind of interesting to me in that, look, okay, so we're looking for excellent management of seizures. We probably can't change inability to drive, but do we ever care about the employment status of our patients or give them any help with that? And how much do we deal with fatigue? There are treatments for fatigue and interventions for fatigue that can be given, and so we're looking into that now. But this is a big determinant of quality of life, yet we never manage it. So this was sort of our first 2 years. So then we went on, what were the next steps? Well, we needed to expand our cohort, we needed to get the longitudinal data, and then really it was sort of the same stuff. So now we're into our 4th year, and this is where we're up to with over 500 patients now. And actually I'm going to continue this. I think we need a cohort of about 1,000 to really get meaningful data. So it's easy to collect. We're going to continue collecting. The scale on this is different, so it looks different to the other graph. Just take note of that. But you know, the results are sort of coming out about the same, but the differences are becoming more marked with more patients. We can really see what's happening. Interestingly, most patients, you know, including a lot of patients with physical disabilities, don't see their physical health-related quality of life as being that bad. But over here on cognitive and social function, you know, patients really see that they're doing badly with that. We're talking about, you know, a lot of patients with 2 centimetre convexity meningiomas or small acoustics here who are saying my cognitive function is terrible and socially I'm isolated. Now, this is a big deal. The asterisks is, this is p less than 0.05 and 2 asterisks is p less than 0.01. These are significant. You also need to think about what's clinically meaningful though. And so you need a change of about 10 points on this scale to be clinically meaningful. So really, you know, these are the ones that are most important, although of course in here where it might not be seen as clinical meaningful as a group, of course for individuals it is. And with that now 500 patients, what are the determinants of health-related quality of life? They've expanded a little bit. So poor global quality of life is most associated with poor subjective conditions still, and with social function, but also unemployment, inability to drive continue to be huge. Being single has come out. You need someone to help you out. Recent seizures, and for some of the other subscales like social or whatever, being female, being younger is bad for your social quality of life, being older is bad for your physical quality of life, and anti-epileptic use. And what are determinants of subjective cognition? Again, communication, but fatigue, huge. Future uncertainty, motor, pain and headache, a really big thing, but we never really manage this properly, I don't think. Sleeping difficulties, radiotherapy obviously, and seizures. So we thought, well, we probably would, we probably should explore cognition a little bit more. Is it really this bad? Like, are these patients really stumbling around, unable to function cognitively? So the first thing we did was look at cognition with the mini mental state, which is a blunt instrument, but it was easy to do. So this is a cohort of 287 of our patients. It's hard to graph because these are sort of binary plots, but different symbols are different patient numbers who had that combination of cognitive score on the health-related quality of life scale versus mini mental state score. And you'll remember that this is a screening test, and above 24 is considered to be normal. So, you know, most patients sort of thought they were functioning okay and were functioning relatively okay. But some patients thought they were pretty impaired. They were scoring themselves 50, 60, 70, and yet they were scoring well on the mini mental state. And look at this. 0 for cognition, health-related quality of life, and yet normal on the mini mental state. And that's, you know, that was quite a lot of patients who were scoring really poorly, self-scoring, and yet doing well. And then, of course, these people over here are scoring poorly, but they don't know it. So, you know, lots of things to manage there. So we thought, well, we probably haven't done the right test here. So we'll do this, something called Cogstate, which is an online neuropsychological testing company from Australia. They do a lot of clinical trials, testing, dementia trials, and head injury research, concussion research. So it's just on a laptop, and there's a bunch of tests that you can do. Looking at processing speed, basically detecting cards, you know, this card, that card, one back test, processing speed, attention, working memory and processing speed, and an executive function of a maze trail making test, which are all standardised tests. And it has a 695 person normalised population, so the normalised score is 100, but anywhere between 90 and 110. So for 100 of our patients, we've taken them off into a quiet room and done the Cogstate and put that against their self-scored cognitive function. So here are our results. So they don't do too badly. When you think that normal is anywhere between 90 and 110, we haven't got anyone here who's in Mensa yet, but you know, people score sort of about normal, and certainly within normal for most, although there is a significant, but is it clinically significant? It is for some people, but as a whole not, significant deterioration. This is processing speed. So being a little bit slower in recognising a previous card. But other than that, most people score relatively normally. And if we look at that same sort of plot as what we had for the mini mental state, where we score against their perceived cognition versus the Cogstate neuropsychological testing score, we find, you know, that, so if this is normal, the normal population perceive themselves at about 90, and 100 is the sort of the normal, and this is the range. Most people, you know, score themselves okay, but there's a significant number of people who score themselves very impaired, particularly these people, and look at that, they're all meningiomas. It's bizarre. They score themselves as very low, and yet and yet they function very well in general. There's a couple of people who are a little bit low, and again, even this group score very well, and yet say that they have significant cognitive impairment. So what does that mean? Well, that means that we need to manage fatigue, and we need to manage sleep. We need to have excellent seizure control, and we need to look at the determinants of a perception of poor cognition in these patients, because we can make a big difference to their quality of life. We need to manage their pain, manage their chronic headache, and so we've got sub-studies going on with all of these things just starting at the moment. So hopefully we'll have some other results. So one of our other questions was, what was longitudinal quality of life? And my sense was that if you start out miserable, you stay miserable. And if you start out happy, you stay happy. Now, as a group, this seems to be true. So this is between, you know, people. We've now got people who are up to 4 surveys, but, you know, for a reasonable size group, we're really just looking at survey 1 and survey 2. I think this is 176 patients. And no matter how you look at it, there's not much change in global quality of life between 2 visits as a group. But what does that mean for the individual? So for the individual, the first thing is, so these are the tumour types: acoustic neuroma, meningioma, and low-grade glioma. It's hard to work out how to graph this so that it's meaningful. So for a start, these are just the patients who had a change of 10 points or more. So if you look at the numbers, half the patients, they don't change. They stay at whatever they were at. If they were 70, they stay 70. If they were 30, they stay 30. They don't change, which is sort of interesting because there's significant time after surgery. They should be sort of on an upward trajectory the way we would think about it. But these are the ones who've had a change graphed against time since surgery. And as you can see, it's just all over the place. It can be up, it can be down. So how we're going to manage this is going to be interesting, and how we're going to actually help these people. I think we're going to need to just decide on a set of symptoms that we need to manage better and hope that that then changes this trajectory. But it's interesting. Obviously, there are a lot of other influences going on here. So what are our conclusions so far? Health-related quality of life is significantly reduced compared to normal, but probably not as much as we thought it was going to be, particularly for low-grade gliomas, and more than what we thought it was going to be for people with what we would consider surgically cured benign brain tumours. So, you know, the results, the spinal patient results and the low-grade glioma versus the benign brain tumour results are probably counterintuitive, but there they are, and that's what we need to manage. I think we've got a big enough cohort now to say that they're real. Self-perceived quality of life is often incongruent with clinical status, and we need to pay attention to that. Some domains and symptoms are more important determinants than others, particularly perceived cognitive function, fatigue, pain, things that we often may not pay attention to. And symptom burden probably largely affects the subjective cognition. And that there are a number of important determinants of health-related quality of life that we don't address clinically, but which have the potential to significantly improve our health-related quality of life. I think I might stop there.
Thank you for that brilliant talk. You know, we always tell the residents that, you know, you do an aneurysm, you do them there, fine motor movement is fine, as though they're doing great. And I think her talk shows they're not doing great. I think my question is, and you could argue that these patients with brain tumors need to be on antidepressants, and whether that would make it, you know, stroke literature, half these patients have depression, you put them on antidepressants. But I wonder if your study, you know, what would happen if you put them on antidepressants, and it'd all probably be euphoric then, but it's just something to think about.
So we haven't looked at depression yet, and that's going to sort of be another sub-study for sure. I actually think what we most ignore is fatigue. You know, these patients really, really complain of fatigue. You know, there's a lot of literature about how to manage fatigue. There are interventions, a sort of a side study of this, which I was going to talk about, but I've kind of run out of time, and that's fine, is looking at online interventions for these patients. Our patients often live a long way from the hospital. So you know, there are occupational therapy interventions for fatigue. There are drugs for fatigue. There are ways of managing fatigue. We've got a sub-study looking at a very fancy sleep monitor in these patients. There are ways of treating and regulating sleep. But I think they're things that we really, really don't pay attention to that are probably going to be more important.
Any other questions? Yeah, Yigal.
Sexual life is also part of quality of life. What do we know with this group of patients, especially those with the low grade and the high grade glioma?
You've just come up with another sub-study for me now. I can't answer that. I don't think we know very much at all. We know that there's relationship discord. We know that people feel emotionally further apart, but I don't know anything about actual sexual life.
Christina.
Do you share the results with the patients? Because I think sometimes the patients are very fearful in the brain surgery and, oh yeah, you tell me I'm cured, but what if I'm not cured? That worry in the back of their mind. Do you share that to maybe...
The cognitive results?
Yeah.
Yeah, we actually have started to do that. And that came from one of my medical students who started doing the cog states, and he said, oh, it makes the patient so nervous. And he said, I always tell them when they've done well. And I thought, you're a really nice person. And then we started to tell patients, because the most of them, you know, normal range. And they're really happy with that, and it makes them feel much better, whether or not that sort of has a lasting impression. And of course, you know, it's a small battery, so I think if we went deeper, we would obviously find more deficits. The point is whether they should really stop them from functioning normally. And of course, we don't know that they haven't slipped. You know, we know they're in the normal range, but what if they were up here before? So there's some problems with sort of just telling people they're normal. But yes, we do start sharing them now.
Mike? Well, it's important work, and it's interesting because we're seeing a shift around these values for providing a good patient experience. It shows you how complex this is. So you had the slide of patients being controlled. I sort of took a double take because there's work, for example, if you look at patients with adult spinal deformity, they self-rate their quality of life is worse than cancer patients. Yeah. But there's also, we just have looked at patients with cervical myelopathy, and we were looking at mild, moderate, and severe. And mild cervical myelopathy, patients self-report on SF-36 and other outcomes like that, quite a substantial reduction in quality of life that's not that different between moderate and severe. And I think one of the learning points is that once patients lose neurologic function, they lose independence, it has a big impact on their quality of life that necessarily then doesn't linearly follow the outcome scales. I think sometimes we tend to blow patients off a little bit. I mean, they've got these mild abscesses. Thinking about that, but you know, it's a hard, you know, it's kind of hard to, you know, it's hard to get around. But I think it's just something for us. It's important for us to be aware of that to help us to counsel the patients.
Our view is not their view. That's really important. And the other thing is the idea of response shift. So, you know, once patients have sort of gotten used to the idea or decided that this is the new normal, then they score themselves differently. But there's also about expectations, you know, exactly what they think should happen. And there's also something around, particularly for the low-grade glioma patients, if I say I'm okay, then probably the tumour is not growing. And so there is a real, you know, I get a sense, and we're exploring this now, that people report a good quality of life because they don't want to pay attention to small things that are concerning them that might mean the tumour's growing, which is not there in the benign brain tumour people.
Hi.
Did you find their perception of their deficit is related to the location of the tumor? Because in the stroke literature, if you have a right-sided stroke, deficit may not be as severe as a left-sided stroke, but left-sided stroke usually reports less of a perception of their deficit.
So we've not analysed that yet. All of the literature would say that yes, their health-related quality of life is worse on a left-sided than a right-sided tumour. But you know, we'll have to do that on a smaller subgroup because, you know, I think that's irrelevant, for instance, for the acoustic group. And it's irrelevant for a lot of the small meningiomas. So we're sort of trying to get bigger numbers for the low grades, but we will look at that. But I mean, the literature's pretty clear on that already, I think.
Yes.
Great talk. I have seen the acoustics did relatively well as opposed to the other group. And you know, the vestibular dysfunction group in acoustic, I don't know if you did a subgroup analysis of vestibular dysfunction, vertigo, and dizziness. Those are the three, you know, things which are actually feared more than the even facial and the hearing deficits itself. I don't know if you did a subgroup analysis.
They all say they're dizzy. They're all miserable.
Right.
I mean, but pain is their biggest thing. So if you look at our vestibular schwannoma group, chronic headache is their biggest problem, which you know, goes on for years and years. But dizziness also. But we haven't done a subgroup analysis because I guess my way of looking at this is what are the big picture things that we can change. So, you know, lots of people have done dizziness, facial palsy, whatever, for for vestibular schwannoma arguing for one kind of treatment or another. I'm actually taking, just a fairly clinic view of what are the things that are actionable. I don't even do the acoustic surgery. I can't change their dizziness, but I'm looking after them in the clinic. What are the things that are actionable? Now, vestibular rehab, of course, might be something that makes a difference.
I think personally sometimes we don't spend enough time with the patients post-op. We walk in, you're great, you're out, and one of our favorite therapists, Amanda, sitting there, they spend much more time because they'll walk the patients, and I think sometimes they have a most sensitive indicator as to how the patients are doing. Because we tend to be, you're moving a hand, great, next. And would you agree with that? I just feel sometimes we are just so much in a hurry, boom, 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 we're out. That's not enough.
Well, I actually tend to spend a lot of time with the patients, but maybe this is where this study comes from. I have quite a large practice of low-grade glioma, and I've become a little bit of a subspecialist in people with low-grade gliomas who want to have babies.
Oh, wow.
Which is, that's a lot of. Let me tell you, the moment a young woman's diagnosed with a low-grade glioma, the first question that comes into both her and her partner's mind is, should we have a child right now? And so, I've spent a lot of time with people.
Such a sensitive topic. Those of you, we had a book and movie club on Paul Kalinathi's book when Brett became there. And Paul Kalinathi had perhaps a year to live, and he decided to have a child. And we all thought about the moral ramifications if somebody's going to die in a year, should they or should they not have a child?
But the best line from that book is where she says to him, if we have a baby, when you die, won't it make it harder and sadder for you to go? And his response is, yes, wouldn't that be wonderful? And that's what I talk to my patients about. I mean, it's not my choice, but yeah, I've delivered, well, not personally caught them, but delivered a lot of babies.
Well, thank you so much again.